I'm not going to put on a microphone, but I don't need it. Thank you all for coming. I have a very special guest today, who's near and dear to my heart. Dr. Adashi is going to be presenting our, what is it called now? Not Grand Rounds anymore?
No, it is Grand Rounds. That's just the CME.
I like the term.
The regularly scheduled series.
That's it. A regular scheduled series.
Yeah.
Okay. Dr. Adashi is going to be our presenter today. I've had the pleasure of knowing Dr. Adashi from the time that I was sitting in your chair as a first-year resident. So that's a long time. It's a really long time. Thank you. But I have known Dr. Adashi, and he's been a mentor, a friend, for all of that time. Dr. Adashi did his training at Shreveport, followed by residency at Tufts, reproductive endocrine fellowship at Johns Hopkins in Baltimore, Maryland. Then he came to the University of Maryland, where he was the division director of reproductive endocrinology and had the distinction of sending many of our fellows, our residents onto fellowships in reproductive endocrinology. He then journeyed north onto Utah to become the chairman of OBGYN, and subsequently went into the cold tundra to be the dean at Brown University. Dr. Adashi, in addition to being just an eloquent and worldly figure, has also been a tremendous contributor to the field of obstetrics and gynecology, having probably, as I say sometimes, single-handedly defined the ovary and its multiple functions. He has since then gone on to do even broader things, now as in his current role, looking at things such as healthcare policy, and I mean really healthcare policy that's going to be guiding us for the next generation to come. So I'm not going to delay, so I'm going to introduce Dr. Adashi to speak to us today on iatrogenic and demographic forces in action, multiple births.
Very good.
Thank you, and thank you all for joining me today. Real pleasure to visit for the first time and really discover a vibrant, active, dynamic universe. So thank you for the opportunity, and I do hope I can share some of our thoughts on this important issue. What I'm going to try to do today is to do some justice to a paper we published now almost a year ago that attempted to cover the ontogeny of multiple birth in the United States over the last 50 years or thereabouts. The reason being that the history of fertility promotion in the United States is just about as long. And we know that the lion's share of the difficulties we are encountering with multiple birth have everything to do, not everything probably, but most everything to do with fertility promoting therapies that were introduced in the late 60s and beyond. And we'll, of course, say something about that. I'm specifically going to try to characterize for you the dimensions of the problem. I will say something about the directionality thereof, where it's heading. And finally, we will close with a discussion of the drivers or the component parts, the elements that make it happen and that we need to target if we're going to make a difference or change course. I use the term epidemic loosely here. I'm obviously not trying to connote a communicable disease that is spreading by the herd phenomenon. What I'm really trying to connote, and probably my predecessors did, is the magnitude of the issue or the scope of it all, in that it seemed to have gotten out of hand, especially in the 90s, which is exactly when some of our colleagues have begun to address this issue as an epidemic. This is a paper from 2004 that, to the best of my knowledge, represents the first published use of the term epidemic in this context by Alan Templeton, who at that time was the president of the Royal College of Obstetrics and Gynecology in the United Kingdom. As we look backwards, though, at the magnitude of the problem, we recognize that, in retrospect, the worst year in terms of multiple birth in the United States turns out to have been 1998. And that is perhaps a good year to perhaps give you some sense of the overwhelming nature of the problem and why a great deal, many of us have decided to take a closer look at it, maybe revise some of our policies and try to change course if at all possible. In 1998, approximately 27% of all twin infants born in the United States were deemed to be iatrogenic in origin. That is to say, man-made in some fashion or another, clearly not intended by nature. That would amount to about 30,000 or so twins born that year out of 111,000 total. We have approximately 4 million births, as you may know, in the United States, year in, year out, give or take. 30,000 iatrogenic twins back in 1998. That same year, 84% of all the higher order infants, that is to say triplets and higher, were iatrogenic in origin. That amounted to 6,400 births out of about 7,600 overall. So almost every higher order infant born in 1998 was iatrogenic in its origin, was clearly not intended by nature. What we didn't even know in 1998, and we didn't include it in the paper, was that in 1998 we also had 627 quadruplets and 79 quintuplets in the United States. And given the incidences that we know we might expect under natural circumstances, this is way and beyond any numbers that you might otherwise see in nature. We could count those for the 4 million births we have on one hand, essentially, and yet we had hundreds of those. This was quite jolting to us because it was a discovery we made after the paper was published. And as we look towards the present, it's not as if we have eradicated that phenomenon. So even as we speak today, we have way too many higher order multiples of this order. I refer to those as extreme forms of plurality. And for those of you who are familiar with hospital lingo or hospital accreditation lingo and have heard the terms never event, that is to say, a clinical event that should have never happened, a term we reserve usually to operating on the wrong side of a patient, operating on the wrong patient, or leaving behind instruments in a bodily cavity. These are serious deviations from quality of practice that have significant repercussions relative to hospital accrediting agencies. And what I'd like to suggest to you, that at least in the context of IVF, but perhaps with other technologies as well, there is really no good reason in 2015 that we should have quadruplets or quintuplets in association with that form of therapy. I would in fact like to suggest that these kinds of outcomes in the context of in vitro fertilization anyway should be never events. We have gone well past this at this point and really should not be having to face it, nor should the women in question. All of this is inextricably linked, of course, to the history of fertility promotion in the United States, which more or less parallels the period we are trying to cover. It all began in 1967 when the FDA approved the first ovulation-inducing drug known as clomiphene citrate, and 3 years after that, a gonadotropin of urinary origin known as human menopausal gonadotropins. Now, to some of the medical students here, maybe even the residents, it might seem that these agents were around forever, certainly since the Big Bang. but they're not all that old. And the reality was that for those of us who practiced in and around that time, most of what we could offer the infertile couple was a referral to an adoption agency, because we had very, very little to offer. When these agents finally came onto the scene, for the first time, we were at least able to bring about ovulation in women who were otherwise unovulatory and unable to do so on their own. And then in 1981, IVF came to the US shores, and I don't have to tell you, life was never the same again. The first IVF baby was born in the United States in 1981 in Norfolk, Virginia, and thereafter, clinic after clinic was opened all around the United States. As we speak, there are about 500 IVF clinics around the United States. Last year, we have done collectively about 175,000 cycles of IVF nationwide. And so in the years since 1981, of course, the volume has kept increasing, and it has yet to plateau and or slow down. And then in 1987, the last, I would say, enduring fertility-promoting therapy was introduced. It is known sometimes as superovulation, at other times as hyperstimulation, and by various other names. In essence, it's a non-invasive alternative to IVF. It's an outpatient procedure. There's no retrieval of eggs involved. All there is the stimulation of women with either clomiphene or gonadotropins, and at the appropriate time triggering ovulation and following this with a timed intrauterine insemination. Some have referred to this procedure as a poor man's IVF because it is far more affordable, and we tend to do quite a few of those before we ever refer women to IVF. So a substantial number of those cycles are in fact undertaken nationwide. Lastly, I want to say a word or two about the databases that we used to carry out this study. And we heavily relied on databases that are maintained and curated by the CDC. The first database that I'll mention is derived by the so-called National Center for Health Statistics that maintains the natality reports in the United States. All those 4 million births that I mentioned earlier, all those 4 million birth certificates that are generated are transferred from 50 states to the CDC in Atlanta, where the data are aggregated so that a national picture emerges. These data are then sliced and diced in a whole manner or form, and ultimately placed online for anybody to see. These data are available all the way back to 1915 in the United States and are really the mark of a developed nation. Without data, you cannot formulate policy because you really don't know where you're heading. With data, you can at least consider the circumstances and hopefully make informed decisions. This happens to be a screenshot of the NCHS website. If you're interested in birth, you'll go to this page and you'll drill down further to your heart's delight. The data are rich and analyzed in any fashion you might imagine. The second database is a little more specialized because it is dedicated to IVF. This is the National IVF Registry of the United States. Every one of those 175,000 IVF cycles I mentioned, not me, might be yours though. Any one of those 175,000 cycles that I mentioned is reported to the CDC by those 500 clinics. So if you chose to look this up, every one of those cycles is in fact online at the CDC. The CDC then takes it upon itself to aggregate those data to create a national report, but in addition, it creates a clinic-specific report. That is to say, there are 500 clinic-specific reports on that website that describe in great detail the performance and the outcome of every one of those IVF clinics. It's a remarkable example of public-private partnership. It's a remarkable example of transparency, which we are all striving to in medicine, but are making only relatively modest, slow progress towards. And I don't really know that there are many other disciplines beyond ours that actually has achieved this level of coordination and transparency. And I say so because we as a discipline may not be fully aware of it, may in fact not advertise it enough, may not in fact feel too proud about it. We really should, because it's a very unique example of how perhaps things should be done in every discipline. And for those of you who are health consumers or will become health consumers, having those data online for the public to see is immensely helpful. If any of you needs knee replacement, good luck. This happens to be a screenshot of that database, which only dates back to 1997 for a variety of historic reasons, but it's essential and is guiding our national health policy when it comes to IVF. If you're interested in data for 2010, you'll go there, you'll click, and we can go from there. You could look up Louisiana at your leisure, and you'll see every single clinic from Louisiana listed in that database for anybody to see. In the next few minutes, what I'd like to do is to discuss with you the ontogeny of the national multiple birth cohort over the last essentially 50 years, from 1967, when the first ovulation-inducing drug was introduced, to the latest year for which reliable data are available. And I would then like to break this down to its component parts. This is the total national birth cohort, but it's comprised of an IVF birth cohort, a non-IVF birth cohort, and of course, a tiny little spontaneous birth cohort. If you add those three up, you end up, of course, with the total. And I'd like to start with the total because it gives us the national direction and the national state we find ourselves in today after those 50 years. Let's begin with tracing the national twin birth rate. As we trace the national twin birth rate from 1967 to 1981, which is when IVF arrived on US shores, there's not much to write home about. Relatively steady, stable, not a lot of change. But as soon as IVF arrived, and later on we superimposed superovulation with intrauterine insemination procedures, we clearly have experienced a significant increase in the national twin birth rate. If there is a silver lining here, it is that in the last several years, that rate of increase has slowed down some. You can tell a few temporary plateaus, but then again, it picks up as it did, and we have yet to see a reversal of course. In fact, as you can tell, 2013, in retrospect, was still the worst year ever, because we're still going up, and we have yet to see a downward trend. It is precisely this phenomenon that has prompted several experts to suggest that the United States is likely to be a twin nation for some time to come, until such time that we transition to a circumstance wherein most IVF transfers are single embryo transfers, and we will come back to that point, and until such time that non-IVF procedures are either diminishing in frequency or are conducted perhaps with great care in a smaller number of centers overall. In quantitative terms, this particular slide represents a 1.7-fold overall increase in the national twin birth rate in the time we covered, a mean growth rate of 2% per year initially, slowing down later into 2 recent temporary plateaus. We have yet to realize a reversal of course, as I said, and unfortunately 2013 was still an all-time high because we have yet to see a change in the directionality of the national twin birth rate. Moving now to the higher order birth rates, once again, as we trace the first 15 years or so of this ontogeny, not a whole lot has happened, stable as it goes. But as soon as IVF was introduced and later on other fertility promoting procedures were added, we have seen a very steep increase in the national higher order birth rate. And as you can tell, 1998 was in fact, in retrospect, the worst year ever in this regard. The silver lining here is that since that time, we have mercifully seen progressive, persistent, significant decrements in the national higher order birth rate, which at this point represent almost a 40% decrease from the 1998 high. So as we summarize the quantitative aspects of this slide, in this case we have seen a 6.7-fold increase to a 1998 high, a 38% decrease since that time to 2013, but that leaves us still with a residual 4.1-fold excess when we compare 2013 to 1967. And I suspect that as we get additional data, and we'll get the next set of data in about a month, we will likely see further decrements in the national higher order birth rate. So the trend, if nothing else, is moving in the right direction. And we draw, of course, a great deal of satisfaction from that, because that is a collective, voluntary effort on the part of all involved. Since there are really no extraneous forces that force anybody to change their practice patterns, this is all done by practitioners who over time have obviously refined their overall strategies. So in summary, as we summarize these 5 decades of multiples, I would say the dimensions of the multiple birth epidemic still remain substantial. It's way too early for us to rest on our laurels. I would also say that the directionality of the epidemic suggests that it may be cresting, suggests. And I say so on the strength of 2 observations. First, that the twin birth rate growth may be slowing down, although it yet has to reverse. But more importantly, that the higher order birth rate has clearly been receding. So possibly the worst is behind us, but we clearly have work to do, and everybody recognizes this, and I think is working towards that. Now, to break this national data set into its component parts, I'd like to begin by sharing with you what happened to the IVF multiple birth cohort during the last 15 or 16 years of that 50-year course. And when we look at the IVF birth rates, and now we're looking only at babies that were born as a result of IVF, so we're no longer in the national mix. The most striking trend you undoubtedly detected by looking at this slide is this remarkable decrease in the relative rate of higher order multiples amongst IVF babies. This adds up to approximately an 82% decrease, which is a rather remarkable decrease over a 15-year period. During that same time, we have seen the singleton rates rise by about 31%, which is a good thing, although of course we would like to see more of that, since singletons amongst IVF babies still only constitute 56% of all IVF birth, as compared with, say, 98% in the population at large. As for twins, for all practical purposes, the incidence of twin birth rate amongst IVF babies has been steady, although you can detect a small decrease beginning to be evident here. And we're so pleased about that, that despite the modest nature of it all, we like to refer to it as a decline, even though all we can report at this point is a 5% decrease in the last year in which data were available as compared to the year just prior to that. That results in a circumstance wherein 41% of all IVF births are still twins, as compared to, say, 2% in the population at large, which leaves much room for improvement, and everybody recognizes that to be the case. Now, the reason that we see this dramatic change, of course, in IVF birth trends has everything to do with the embryo transfer trends, simply because, by and large, the more embryos you transfer, the more infants are likely to be born. And so it is useful to review the embryo transfer trends during that same time period. And in a sense, you're looking at a mirror image of what I just described for the birth trends within the IVF cohort. The most striking change being this dramatic decrease in the relative fraction of embryo transfers that involved 3 or more embryos. This adds up to a decline in the fraction of 3+ embryo transfers from 83% back in 1997 to 20% down in 2012. This is, again, a remarkable form of progress, which explains to a large degree what we have seen in terms of IVF birth. But it is also sobering to realize, going back and looking at 1997 and realizing that at that time, 83% of all IVF transfers involved 3 or more embryos. No wonder in 1998 we had a whole lot of multiples. We were transferring a whole lot of embryos back in those days. At the same time, if you transfer less in the way of 3 embryos, you'd be transferring more in the way of 2 embryos, or you will be conducting double embryo transfers, and those have gone up from 12 to about 55%. We've also increased concurrently the relative fraction of single embryo transfers, abbreviated SETs, which have gone up from 5 to 25% of all transfers, which is a good trend, and we would very much like it to increase to a point where the lion's share of transfers, when indicated, are in fact single embryo transfers. Even this picture is a tad too rosy and somewhat misleading in that it comprises what we call elective single embryo transfers and non-elective single embryo transfers. What we mean by that is non-elective single embryo transfers are circumstances wherein all you have is a single embryo, and that's what you transfer. An elective single embryo transfer is a circumstance where you have multiple embryos to choose from, but patient and provider make a conscious decision to only transfer one. Those are the ones we're particularly interested in, and those have only gone up to 11% of all transfers. Again, pointing out the fact that while we are on the right trajectory and making progress, there is clearly more work, more room for improvement. And if you asked me what is the central question in reproductive endocrinology today, probably there are 1 or 2 others, but perhaps one of the leading questions is, what is the future of single embryo transfers in the United States? Or rephrased, how do we get there? What is our strategy? What is the likelihood that we'll get there? And on what time course can we expect this to transpire? Another way of putting it is, are there lessons we can learn from other national models? can we observe the ontogeny of other nations and try to recapitulate it in some meaningful fashion? And to explore that possibility, I'd like to take you briefly through the ontogeny that transpired in Australia as a parallel continent and show us at least what is possible, not necessarily what is feasible, but what is possible anywhere in the world, maybe only feasible in Australia and not in the United States, but nevertheless instructive. What you're looking at on the left-hand side is the slide I've just shown you, which reflects the trends of embryo transfers in the United States over the last 15 years. Single embryo transfers on the way up, crossing the 20% line, 3+ transfers well on their way down, crossing the 20% line, and double embryo transfers more or less steady. And that's where we were in 2012. If you now look at Australia, you realize that where we were in 2012, they were already at about 2002 or thereabouts. And then something happened. They ramped up their single embryo transfers consistently and dramatically to a point that it probably now approximates 80% of all transfers. Concurrently and inevitably, they diminished the fraction of double embryo transfers, which went down dramatically, and effectively eliminated 3+ embryo transfers. So if you were to ask me, does Australia have a multiple birth epidemic? The answer, of course, is no. They have licked it. And the question is, how did they do it? And if they can do it, could we potentially do it? And by that I don't mean could we do it, but do we have the kind of system or circumstances that would permit us to do it? Now, the question of how did they do it or what was the Australian solution is the following. They have made a two-pronged decision. First, they committed nationally and voluntarily to single embryo transfers, and they provided, very importantly, what I call dream IVF or assisted reproductive technology benefits. That is to say, insurance coverage that was nothing short of optimal. That insurance package included 80% coverage of all outpatient IVF costs, subject to a deductible and a cap, unlimited number of IVF cycles, and eligibility that was independent of how old you were, how many previous IVF cycles you tried, and how many children you might have. It doesn't get much better than that. And so by combining what I would call generous underwriting on a national scale with a commitment to single embryo transfers, the Australians essentially reaffirmed what is now a universal principle. When you do those two things, you can pretty much count on plurality risk reduction. You can't do one without the other. And that's been done in Europe and in other nations all around the world. Nations that in many ways are very different than the United States. And the key statement here is America is not Australia. And some of you might conclude that that is an understatement of multiple dimensions, but it is very apropos when it comes to our very distinct healthcare systems. The notion that we will have a nationalized healthcare system wherein every American will be covered for infertility benefits seems very remote, not very likely to happen in our lifetime. At present, underwriting for infertility therapy in the United States is very limited. Most Americans are either under or uninsured. All the funding that exists is private. Not a single taxpayer dollar through Medicaid or other forms of governmental insurance goes towards infertility coverage. Most of what couples end up doing is paying out of pocket. It's largely self-funded. There are a few states wherein there is a statute on the book which requires resident providers of health insurance to cover IVF. A total of 6 states in the nation have such a statute. So if you live in those 6 states, you're in luck. But if you live in the other 44, you're out of luck. And if you happen to be working for a beneficent employer, and there are a few, they may throw in infertility benefits into your healthcare package. But all in all, we would have to say that the coverage of infertility in the United States is nothing short of dismal. And I would add to that also socially unjust. Because what that says is that to build a family in the United States of America means that you have to have the means to do so. Any other disease, we don't make that distinction to the extent that infertility is a disease. And at the minimum, it is approximating that state in a variety of ways which we can discuss later. And so for a nation that tends to pride itself on its family values, I'd like to suggest to you that there may be some work that we need to do here if we are, in fact, to mean what we say as opposed to speak from both sides of our mouth. There are consequences here. Patients who are not insured feel very uncomfortable relying on a single embryo transfer. And it's difficult for all providers to, in fact, never mind how committed they are to the cause, to convince necessarily patients that they should proceed with a single embryo transfer, because there is still a prevailing perception that the more, the better, even though the numbers don't necessarily bear that out. And so we are at the point where we need to come up with an American solution that is not likely to be an insurance solution, but is likely to be a technological solution, which may well be an alternative, but will not resolve the cost issue or the insurance issue. But we are, as a nation and as a community, working very hard on optimizing the process of embryo selection and implantation in an effort to get it to a point where we can develop increasing confidence on the part of providers and patients and increased acceptance of single embryo transfer. If we can in fact assure a patient that a single embryo transfer will give rise to a, say, 60% likelihood of a singleton pregnancy to term, I think we will see a very different responsiveness on the part of the patients who see us for infertility. There might also be other things we could do in those settings where commercial payers are involved. There could be some incentives and disincentives injected into the equation. Incentivize providers who engage heavily in single embryo transfers. Disincentivize those that do not or have an exceptionally high incidence of multiple birth. And we'll see some of that in a minute towards the end of my presentation. We could also have more effective oversight by some of our professional associations who are keeping an eye on the multiple birth rates of those 500 IVF clinics, and occasionally, when they deem them excessive, might send them a letter, and in an extreme case, might pay them a visit. It's a subtle form of peer pressure that is not binding, but one that clinics clearly would rather avoid. We could do more of that, and we could do that better. But we should continue to engage in education, because everything you have seen thus far in terms of the declining higher order multiple birth rates and the promise, hopefully, of declining twin rates has been strictly achieved by education, by providing information to patients and providers who, when they see the data, I think in time, respond accordingly and give us the results that we have seen. I'd like to move now to the non-IVF technologies briefly and make the point that even though in most social contexts when IVF comes up, or in professional contexts when IVF comes up and multiples come up, fingers usually point at IVF, implying that IVF is the leading offender, the major culprit. But as our paper shows, that may not be so. And if that is true, then maybe we should refocus our educational efforts or re-energize our educational efforts on non-IVF technologies to which we may not have paid a whole lot of attention until recently. And when I say non-IVF, I mean by that conventional ovulation induction and ovarian stimulation protocols with intrauterine insemination. And the reason those are candidates for generating multiples is because they are not as controlled as IVF. You can't count embryos at the time of transfer. This is all happening in vivo. And despite our best efforts at monitoring that process, it is certainly not perfect. And more often than not, we will see multiple follicles ovulate, multiple eggs being fertilized, and multiple embryos implant. We also do quite a few of those. In some cases, as I mentioned earlier, we might do 6 or more of those before the patient ever sees an IVF procedure. And a lot more of us are doing it. This is a procedure that can be done by generalists and reproductive endocrinologists. There may only be 1,500 or so reproductive endocrinologists in the United States, but there are 50,000 ACOG members who in principle could be undertaking this or other procedures. And we know that both ovulation induction and hyperstimulation are linked to significant birth plurality. In fact, the whole rationale for those procedures has something to do with the stimulation of more than one follicle. So as we look at the data in that same paper from 1997 to 2012, and in this case we are tracing the national twin birth rate and the relative contributions of IVF, non-IVF, and spontaneous birth. Yes, IVF is an actor. It's evident throughout, and it's certainly contributing to the national twin birth rate. But during that same observation period, the leading offender turns out to be non-IVF technologies that appear to be holding their own throughout this observation period. Some of the same is true for the higher order multiples, although the picture is a little more complex. Notice that the contribution of IVF to the national higher order birth rate is declining. But at the same time, the non-IVF contribution at the minimum is holding its own and potentially maybe slightly on the increase. One thing is clear, somewhere around 2001, 2002, the two curves crossed. And at that point, IVF lost its status, if you will, as the leading culprit and was replaced by non-IVF technology, which seems to be producing the most higher order multiples in the United States. Lastly, I want to say something about spontaneous multiple birth and why even spontaneous multiple birth over the last 50 years have not been an innocent bystander when it comes to the multiple birth epidemic. And let me explain what I mean by that. Shown here is a new set of data that we have yet to publish, which traces, in this case, the national plural birth rate, that is to say twins and higher order multiples combined, as a function of maternal age during 12 years that preceded the availability of even the first fertility promoting drug. So by definition, every multiple birth in this data set is spontaneous because it's prior to 1967. So as you trace the national plural birth rate as a function of maternal age, in this case in white women, you will note that the risk of having a multiple birth is age dependent and peaks at about age 35, declines presumably thereafter because of declining fertility, displaying this unimodal curve that many of us have long suspected has never really been all that carefully documented, but very much links the incidence of plurality with age at birth. And if you do the same kind of study for non-white Americans, which in 1960, in the interval between 1956 and 1966, were mostly African American, that risk goes in fact fourfold and then goes down again. So clearly, while we suspected that for a long time, spontaneous birth plurality, among other things, is a function of maternal age and race. Now, when you stop and think about what happened in the last 50 years in the United States, I think we can all agree that we are a very different nation. In 1967 or 66, the average age at which mothers gave birth tended to be far younger than it is today. The phenomenon of delayed childbearing, I don't think need any expanding in this particular lecture room. It's a dramatic demographic and social change that transpired in our lifetime. But the longer you wait, the higher the incidence of multiples. We are also a very different nation in terms of the diversity that we display. And so in the last 50 years, we have become a far more diverse nation than we were in 1967. So with those two parameters changing as well, even spontaneous birth, by virtue of this linkage, have in fact contributed to the multiple birth epidemic. We estimate, and those estimates are still being reevaluated, that approximately 10% of the excess multiple birth in the United States during the period we cover today have nothing to do with fertility promotion, but have everything to do with the fact that we are experiencing, observing delayed childbirth and a far more substantial diversity in our country. We're actually quantifying this in terms of how many twins and how many higher order multiples, etc., and the numbers are not insubstantial. I'd like to close by at least an effort to take a stab at the future and delineate it to the best of my ability. There is no, I think, uniform consensus, but the way I read the literature and my communication with my colleagues suggests that we may be looking at the future wherein IVF would be dominant, and that's why I characterize this as an IVF-dominant future. A future wherein we pursue a more direct path to IVF without the multiple cycles of superovulation or hyperstimulation that I mentioned earlier. A future wherein we perhaps save superovulation and intrauterine insemination for those who cannot afford IVF. And as we have discussed, quite a few American couples cannot afford IVF. It's estimated that about 75% of American couples in need of IVF cannot actually afford it. And we will continue in all likelihood to engage in ovulation induction for anovulation because it's sensible and because it's cost effective. Those women or those couples don't need IVF. And to back up what I'm saying, I'd like to take you to one of those mandated states that I mentioned earlier, specifically the state of Massachusetts. And for that matter, I could take you to Rhode Island because those two states both are so-called mandated states wherein the law requires resident insurance companies to cover IVF. Approximately a year and a half to 2 years ago, these payers issued new policies in terms of how fertility promotion should transpire in clinics in Massachusetts. For example, Blue Cross Blue Shield, for the first time in a long time, allowed a direct path to IVF without any prior cycles of superovulation and IUI. Tufts Health Plan allows a direct path to IVF or a maximum of 2 cycles of superovulation. And I can tell you that 6 months prior to that, they would be insisting on 6 cycles of superovulation and IUI, partly out of the conviction that those are more affordable and would be more affordable to the payer as well. What they did not, I think, at that point, despite multiple conversations with us and others, have not really accepted the tenet that what is really costing the payer is the multiple birth process itself, the NICU proper, and in the case of really premature infants, lifelong care for the disabled preemie. But I think we have turned a corner, and payers are finally aligned with providers on that premise, and their literature is replete with documentation of such. In fact, to a point that the money saved could be used to cover a whole host of IVF cycles that are currently not being covered. And if that is not enough, as recently as October of last year, so really just 6 months ago, Blue Cross Blue Shield of Massachusetts further refined its policies and now is requiring that for women under 35, a single embryo transfer is required during the initial 2 IVF cycles. And for women between age 35 and 37, such single embryo transfer will be required during the first IVF cycle. And then for women who are over 38, a single embryo transfer is not required per se during the initial IVF cycles. And by and large, Blue Cross Blue Shield approves a total of 6 IVF cycles in Massachusetts and in Rhode Island. And so while I'm not going to stand here and say where Massachusetts goes, so goes the nation, but healthcare reform began in Massachusetts, and not long after that, it was adopted by Washington in a somewhat modified fashion. I also think it's fair to observe, and I hope nobody from the Midwest takes offense, that some of these changes often begin on the coasts and tend to seep into the middle, a little bit West Coast, a little bit East Coast, and then ultimately, I think, equilibrate across the nation. To the extent that those assertions are true, even if not quantified or proven, likelihood is that what we are seeing happening in this case in Massachusetts and Rhode Island and some other states may well influence overall policies and overall outlook, even though we recognize that the lion's share of states are not mandated and therefore cannot really in any way be influenced directly that way. With your permission, I will close on a lighter note by quoting Mark Twain, who in 1879 in his baby speech said, "Sufficient unto the day is one baby. As long as you are in your right mind, don't you ever pray for twins. Twins amount to a permanent riot, and there ain't any real difference between triplets and an insurrection." He almost sounds like an ACOG representative. One baby at term is what I think most of us believe is called for. And we are all, I think, collectively working towards that goal, realizing that it will take some time and that it's not a simple equation and that we can't quite copy our European and Australian colleagues, because The US of A is different, and it's not likely that we're going to be able to emulate all those lessons quite like we would like, and so we're going to have to work it out our way, and I know we will. It's just a question of time. So thank you very much for your attention and for the opportunity to share with you what I think is still an evolving story and an important one for all of us who practice OBGYN. So thank you. Please.
In 1998, we were climbing up this trend, and then all of a sudden, they're, slowing down or not doing the multiple embryo transfers anymore. And you said there wasn't a change in national policy or anything. What was going on?
Good point, and I probably was not explicit or sufficiently, I did miss a point. What began to be happening is that our professional society, the American Society for Reproductive Medicine, issued guidelines recognizing that we are in trouble and that we need to improve the situation. They then revised those guidelines over the years, at least 3, if not 4 times. And those guidelines, we have to assume, although we cannot prove that, along with, I think, a growing national recognition of the problem, has gradually changed the tide. Those guidelines, as you can imagine, are not binding. They are just guidelines. We do not have binding policies like you're already seeing in Massachusetts, Rhode Island, and some of the mandated states, and you certainly see in Australia or Europe. These were suggestions, but I think they had an impact. Physicians took to heart what was happening. I think we're trying to do the right thing, and increasingly, I think that led to results. That's why I mentioned earlier how unique this whole effort is in terms of it being voluntary. There are no sanctions that can be applied to misbehavior along these lines. It's a free country. Yes, there are some legal consequences to some of the things we do, but on balance, this was really a goodwill, desire to practice good medicine, and realizing that we may not have been paying attention, and that includes me, in the 90s, as things were getting out of hand. So I think now there's broad recognition of the issue. There are guidelines that at least give one a certain framework to work against. I think there's obviously growing patient awareness and education as time goes by. And so clearly the multiplicity of peer-reviewed papers, including this one, which is now, I think, required paper in REI recertification, for example. So there are multiple forces, but all voluntary and instructional as opposed to prescriptive. And I think that collectively must have made a difference. Please.
You were talking about the cost of IVF and superovulation and IUI. What are the costs generally, just I guess average? And I guess for Dr. Vandermolen, what's the local cost for those two things?
What would you say is the local cost?
Average cost, medications included for IVF cycle would probably be as low as $12,500 to maybe $15,000. Function of the drug doses and whatnot. We need to do assisted fertilization with the interstitial sperm protection.
My guess is if you went to New York or California, you could be as high as 20.
So what about an IUI superovulation cycle?
So home and IUI probably about 900 to 1,000.
Far more affordable. But and that's why it probably cannot be, shall we say, at this point in our evolution, cannot be, and I'm using a harsh word here, cannot be banned as a form of therapy. We need to retain that option for women who cannot afford IVF. But if multiple pregnancy is the focus, those stimulation cycles are producing multiples and significant numbers of those. So the general hope is that we will reduce that over time. But we may not be able to eliminate them because not everybody can afford IVF or even wants to go to IVF. Please.
Just a few comments. First, let me thank you again for coming down to speak. It's a tremendous treat, educational experience for all of us for you to be here. You know, I think it's been for at least a few years now that, you know, members, they do send out letters to clinics that seem to be running high on the Howard multiples rates. Okay. No, I haven't got any, but they do, they do send those out. But, you know, there are several things. And 2 states I've been in, I know groups of RI physicians that have approached the legislature, tried to get insurance coverage for so many cycles of IVF. And you have the physicians on one side, and actually in most cases it was the insurance providers on the other side that didn't want to sign on to this. And even though you present data that says, by so covering it, when you include total costs, not just getting pregnant costs, but the obstetric costs, the post-birth costs and all that, that is cheaper to cover IVF and reduce your multiples, that they didn't sign on. That's one of the comments as well. There's too much moving between the insurance company that paid for the IVF isn't the one that saved the money in terms of when the baby was born. There could have been a change, a move, that kind of thing. But I've found hard to understand the reasoning there, because total cost does support covering IVF. Another comment is, if we move to earlier IVF, and I'll throw out this to the MFMs, let's say you do Clomid IUI, or simply Clomid, we're looking at a 5 to 10% twin rate, most of which are dichorionic. If you do IVF, you may have about a 2%, put one embryo in, 2% monochorionic twin rate in terms of your morbidity, mortality being greater with your monochorionic. Where's the line? You know, is still Clomid at dichorionic safer than a 2% monochorionic? So I throw that out there as well. And but the other thing you can't, and we as do this facilities every day. I can't tell you. I'm glad the slides are blue, because sometimes that's the color of my face when I'm trying to talk people into not putting in two embryos. And some of them still want to. And you know, there's the patient that, oh, I was so pleased. She was a PCOS patient. She didn't want to do OI. She wanted to go IVF, and she wanted us to just put one embryo in. We put one in, and it split. So she had two. So even the best intentions don't work out. Then finally, you know, there's I think a lot of REIs do a lot of education, but then there's the patient behavior element. And yeah, my last set of superovulation triplets was, and we warn couples, you know, at times we have to cancel a cycle. There's too many follicles. Too many follicles, cancel, no intercourse. Don't, sure enough, had intercourse, triplets. Didn't listen. So there is, as Dr. Adashi has alluded to, multiple levels to which attack the problem, and it's going to continue to take multiple efforts from policy to education to patient behavior to make the changes and get the multiples rates down.
It's very complex, and I think everybody, you just highlighted, I think, many of these complexities, and I couldn't agree more with that. There is this difficult dynamic between provider and patient. We know that we need to be careful not to be too paternalistic. It's not our baby, it's not our choice, it's not our body. And we need to give the patient enough room and enough conversation is a conversation that transpires every day in the Office of Reproductive Endocrinologist with great care, hopefully, to adhere to these principles. You did make a point about states that failed to create a mandate because insurance companies lobbied against it. And I can tell you only that in each and every one of the 15 states that have some sort of a mandate, the insurance companies found themselves on the opposite side of the case. Almost all of those were actually grassroots efforts by patients. Some of them remarkable stories going all the way back to 1984 in the state of Maryland, were resourceful couples, mostly women, influenced the legislation to change the law, usually against very significant lobbying power, firepower, by insurance companies. And by the way, this doesn't necessarily end there, even after the bill is passed by both chambers and the governor signs it. Next year, there are efforts to repeal that law, again driven by insurance companies. I think there are clearly still payers out there who do not see the situation the way perhaps the Massachusetts-based payers see it, who we would like to say have seen the light. And it will take some time, I think, until that insight again percolates throughout the nation and payers really understand that they're not saving by holding back on IVF, that they're actually gaining. And it took a long time to get to that point because on the surface this is a counterintuitive conclusion. But there are now numerous peer-reviewed papers, including ours, that have documented the falseness of this presumption. So do I think there'll be more state mandates? That would depend on couples/women mobilizing, because I'm afraid our professional associations have not picked up that mantle. I'm not even sure that we as providers have done what we need to do in this regard. So if the past is any indication, future mandates will be grassroots efforts. What argues against it is the fact that there hasn't been a new mandate for at least 15 or 20 years now, for reasons I'm not fully clear about. But for some reason, we stopped at 15 and never got beyond that. Please.
You think that'll ever go a step further to like Medicaid and, because then you bring up, there's all kind of social issues and ethical issues.
We are actually trying to understand. I'm not sure I even understand who and when made the decision not to cover infertility. We're not talking Medicare here. We're talking Medicaid fundamentally. And of course, that may or may not apply to most of our patients or the ones who show up in IVF clinics. But it would be a symbolic move because what happens, as you know, in the United States, the way Medicare and Medicaid go, so do the commercials. So if the government would recognize infertility as an insurance-worthy entity, there is hope that something will happen. As it stands, for whatever reason, and we're really trying to get into the weeds there to see when and where did anybody actually make that statement or write that regulation or put it in law somewhere. What is it that's somehow precluding us from providing that coverage which the rest of the developed world has chosen to cover? Granted, they all have very different healthcare financing systems, but they made certain decisions, and I'd like to think that we are, by and large, not all that different from Europe and Australia in terms of our human values. And so it's a little surprising that we're persisting at this point in really not covering that entity at all. But it deserves more, I think, study, and more importantly, it deserves much more advocacy and activism. And hopefully that will happen. The current president or executive director of the ASRM, in his address last year, for the first time that I recall, has actually articulated some of those thoughts in his speech, which was published in the Society Journal. I draw some hope from this, and there'll be perhaps a session in the upcoming meeting of the ASRM in Baltimore in October that may be dedicated to this very issue. So maybe, just maybe, we're beginning to see some movement, but much more work needs to be done.
Thank you. Thanks again, Dr. Adashi.